I'm going to ask each of them to, they've taken down the questions, they'll have short answers to each of the questions, two for each of them. So please, Kabir, and I'll then try and wind up in a few minutes.
So I think I had a question from Dr. Rupa about the role of local initiatives in addressing the problems of mixed health systems. So I think there are several examples of that, and maybe you could share your own experience actually in that area. I think there's always this tension between local action and scale. So in India we always have this concern of scale, and that's also indicative of the tension between quality and adequacy. So that's one of the things that I pointed out, that if you're looking at three challenges of adequacy, quality and welfare, very often the types of interventions and the types of policies that address one is not necessarily convergent with the types that address the other. So if you're looking at quality and local initiative, then that might not be necessarily conducive to scaling up. So it is all those, I can think of two examples which maybe have acted in this direction. One is PPM for tuberculosis, in which local initiatives with NGOs have acted to engage private practitioners in a public good, and that's also been active at scale. And of course CBM has been effective in improving government health services. The other question was on multitasking as opposed to single tasking. So obviously siloing of tasks is a big problem in our health system, and probably more broadly in our bureaucracy. So definitely there is scope for any strategies that make roles more flexible. But again, here there's this tension between adequacy and quality. So we need to make sure that training and regulations are adequate even when we do shift tasks. So I think.
One was about the quality of the training. In the initial phases of the NRHM, the quality of training was, the notion of quality in ASHA training was pretty much not there. Modules 1 to 4 were basically knowledge-based, and the quality also varied among the states depending on the commitment of the state and the involvement of the NGOs. For example, in our evaluations, though there were no formal evaluation of the trainees at the end of any training, but in general sense of the levels of the ASHA knowledge, the quality of training could be said that it was better in Assam, Orissa, West Bengal and Andhra Pradesh, while in the remaining states the skills were the knowledge levels were very limited. But with the launch of Module 6 and 7, which are skill-based, the training strategy has been designed in a manner that the quality of the training is monitored at every level, and there is evaluation of the trainers as well as the trainees after completion of every round. So now we are actually trying to implement it. In terms of satisfaction of the ASHAs, if I've understood it correctly, that's what you wanted to know. We actually didn't ask ASHAs directly whether they are satisfied with their job roles or not, because that was an obvious question, what answers would come. But we asked about the challenges that they face in their performing better. About 50% of the ASHAs said that they would need a better regular mechanism of drug filling and payments. Payments to be done not about the incentive amounts, but the way that it's done in a timely manner with dignity. And some ASHAs have been now in the last 1 year, we have been hearing about what he has pointed out, that ASHAs are asking for fixed jobs and salaries. But we should also take into account that over the years we have been just adding on jobs to the ASHA. Everything has to be done by the ASHA. Whatever program it is, whatever outcome we want it from the ASHA. So the voluntary nature of the program, we need to preserve it, and so we need to think about what HLG recommends a second ASHA in the village to take on for the other tasks. So in terms of satisfaction, there were some challenges that they have outlined, but their subjective profile of why they became an ASHA was more or less in terms trying to serve their communities.
Yeah, I have two questions here. One, if there is a policy enhancement for traditional medicine, isn't there a risk that it may end up not being very traditional after all? So to that, I have to say that if it's a wholesale policy and it's not very sensitive to the ethos of the people and of the system, there is very much that risk. But the policy, when you talk about policy for integrating various systems of medicine, it needs to be sensitive to the system of medicine itself. And the spirit of each system needs to be respected. And this includes maybe a different research paradigm for each system and a different way of even conducting education. For example, if oral transmission is the way that it goes in a particular system, maybe that's the way for it to go. You can't change that and make it distance and so on. So as long as the ethos of the system and of the people is respected, then I don't think that there is a danger of the system of medicine not being practiced in a traditional manner after all. But if that is not given attention, certainly there's a chance of diluting it. And the other question was, why is physiotherapy not included? I fully share your thoughts and your sentiment that numerous formal and informal therapeutic systems and systems of health promotion which need to be included, and I can only hope that, you can see it with Ayush, and I'm hoping that it will happen with all these other systems, that they will be recognized and they'll come into play, especially since the disease profile and the health condition profile of the population is changing, and the importance and the relevance of these systems will become more apparent.
I had two questions to respond. One of them was from Werner, which was about involvement of nurses in the study. Apart from one trained qualified nurse turned public health person in the team, we have also getting advice from nursing experts, couple of nursing experts in the country that is there. And second is about the distinction between nursing practitioner and nurses. I agree, but on the other hand, while we are studying the nursing, it's important to look at the nursing practitioner and the task shifting segment, being it is a career progression pathway for the nurses. So that is the way we are looking at it as of now. Thank you.
Thank you. Partly Garima has already answered the first question, that when it comes to Asha's motivation, I think along with a stable small income, being able to serve the community and getting the respect of the community continue to be very significant motivators for a large number of Ashas. So I would not undermine that. Certainly some people may be there only for the money they make, but I think there are many others who are there because they genuinely want to use an opportunity to serve their communities, and they like the respect and regard they get for being people who come to help in times of need. So that's kind of a general answer, and Garima has already given some other suggestions towards that. The second one was more about other kind of benefits. We certainly in the project have looked at and we have data for focusing on what are the shifts that has happened in antenatal care, birth planning and interpartum care. But the issue here is we are trying to present or position this as an opportunity for how new information can be passed on to Ashas in a systematic and easy way, using monthly meeting as a platform for ongoing capacity building and support. So another day, if it requires to be malaria or tuberculosis or any of the other areas that Ashas need to be working on, I think the platform of a monthly meeting can be used as a very viable alternative to provide ongoing learning and support for Ashas. So it does have implications beyond the small segment that we have spoken about. Thank you.
I'm going to just wind up by saying that I've just picked up 4 important, I hope, take-home messages from all these studies that we've heard and also from some of the questions that people have raised. My first is that actually, having been myself for years very involved in human resource health, I started my career in London School of Hygiene in '72, writing on the 3-year BSc in rural health, which, as you know, last week was finally accepted by the Medical Council of India. So it's a long journey, and I would say there's a phenomenal amount of national and global experiments and innovations at local and up to district level, which we don't know about. So I think the biggest sort of challenge for a lot of us health systems researchers is to network and to be able to get at this experiment. And in 1 or 2 areas, like in Ayush, I can say, since I've been working on that for a little while, there's a phenomenal gap. Most of us are not aware at what level integration and pluralism mechanisms and innovations are going on. And I think that's very important. And somehow we have to see how, as a collective, we health systems researchers can really keep track of innovative ideas and their evaluation, monitoring, and learning from them. The second is, which worries me, is this word called task shifting. Because though we keep saying task shifting, what we're constantly doing is role shifting. And one of the best examples is that of Ashas. Ashas were never meant to be. Today I find I go around the country and people are talking about the Asha health worker. In no Asha literature there is working. It was facilitating and activism. It's a social health activist. So what we've done in most states, we've knocked off the facilitation and the activism role. We've given a service provider role, and therefore we have Ashas now saying, you make us regular job people. When they were activists and they were facilitators, they were not asking for jobs. As soon as we've started putting everything on the Asha, newborn care, mental health, NCD, whatever, now elections, all sorts of things will go on the Asha. The poor A&M is very happy now because up to now she was doing it all. Now it's moving to Asha, and there's at least Ashas to hold the A&M's bag and be, for Asha, now you have the A&M Didi and the Asha is now the assistant. So I think it's very important to be careful that here lots of experimentation in human resources where we were trying to bring in a sort of a person, not a worker, some sort of link between the community and the system for facilitating, for monitoring, for accountability, and there is this huge biomedical capture. And I think it's very important that we keep track of that in our health systems research and keep cautioning to the original goal. The other thing is, I have very interesting that in all the studies, there were lots of social, economic, cultural, political determinants, and I can't help feeling that we as health systems researchers have to improve our skills in the social sciences to understand political economy, to understand anthropology, to understand social science, paradigms and so on, so that some of the so-called dilemmas in our data we can understand. For example, if you don't understand gender, you'll never understand the situation of nurses in this country, because it's not techno-managerial, it is really a gender issue. It's patriarchy that prevents, nurses from being, and not only nurses, A&Ms, Ashas, Anganwadis, all the women workers, millions of them, and still it's a very, very patriarchal health system, which is, think of the male doctor and his medical skills, and we always talk about that, so I think it's very important. And the last thing which I liked was the words that the people had used in your titles, and I think we must continue to do that in our health systems research for HRH, let's engage, let's strengthen, let's nurture. Thank you.